Welcome back to the channel. Colleagues, today we are taking a deep dive into emergency pulmonology and acute asthma exacerbations. When a patient arrives at the emergency department in acute respiratory distress, our immediate priority isn't just handing them an Albuterol inhaler. It's rapid clinical triage and severity stratification. We classify acute asthma exacerbations into three main categories. First, mild to moderate exacerbation. The patient here speaks in phrases, prefers sitting, has a big expiratory flow or FEV1 of 50 to 80% and oxygen saturation of 90 to 95% on room air. In severe exacerbation, the patient here speaks in single words, sits in a tripod position, has a respiratory rate more than 30 breaths per minute, displays accessory muscle use. The rate of PEEF over FEV1 less than 50% and oxygen saturation less than 90%. In life-threatening exacerbations, the patient is drowsy, confused, and exhibits a silent chest, meaning airflow is so constricted that wheezing stops completely. Now let's break down the emergency pharmacotherapy into four distinct pillars. First, controlled oxygenation and short-acting beta agonists, or SABA. We titrate oxygen to maintain an oxygen saturation of 93 to 95% in non-pregnant adults. Avoid unnecessary hyperoxygenation. For bronchodilation, Albuterol is our primary agent. In the first hour, we give 2.5 to 5 mg nebulized every 20 minutes for 3 doses or 4 to 10 puffs via MDI with a spacer every 20 minutes. Here is a classic board exam question. Is continuous nebulization better than intermittent nebulization? The answer is continuous albuterol at 10 to 15 mg per hour reduces hospitalization in severe or refractory cases, but intermittent dosing is equally effective in mild to moderate presentations. Moving to pillar 2, ipratropium bromide. Adding ipratropium to albuterol during the first hour in the emergency department significantly reduces hospitalization rates and improves FEV1 in moderate to severe exacerbations. However, discontinue ipratropium once the patient is admitted to the hospital ward. Clinical trials show no added benefit for continuing ipratropium during inpatient ward care. In pillar 3, we have systemic corticosteroids. Administer steroids within 1 hour of emergency department presentation for all moderate to severe exacerbations to reduce airway inflammation and prevent relapse. We dose prednisone or methylprednisolone at 40 to 50 mg daily for 5 to 7 days. Remember, oral prednisone is absorbed rapidly and is equally as effective as IV methylprednisolone. Reserve IV steroids strictly for patients who are vomiting, intubated, or unable to swallow. Now, if the patient fails to respond after 1 hour of intensive therapy or presents within an FEV1 less than 25% to 30%, bring in pillar 4, intravenous magnesium sulfate. A single dose of 2 grams IV over 20 minutes inhibits calcium influx into bronchial smooth muscle, producing prompt bronchodilation. Finally, What should you avoid? Guideline consensus explicitly advises against routine IV aminophylline and routine antibiotics in acute asthma unless there is clear evidence of a concurrent bacterial infection like fever and purulent pneumonia. Once the acute exacerbation resolves, we must transition the patient to appropriate long-term controller therapy under the GINA guidelines. We have two tracks. Track 1, which is preferred strategy, low-dose ICS, Formoterol as reliever. Because Formoterol has an onset of action as fast as Albuterol, using it as a reliever delivers anti-inflammatory corticosteroid protection with every rescue buff, cutting future severe exacerbation risk dramatically. And we have alternative track, which is track 2. We use SABA as reliever, which must be paired with mandatory daily ICS maintenance. Now, if severe exacerbations persist despite high-dose ICS plus LABA adherence, evaluate for biologic therapy. And there is a hint. Choose the biologic therapy based on biomarker profile like IgE, blood eosinophil count, and fractional exhaled nitric oxide. And here we have multiple choices like omalizumab for anti-IgE for severe allergic asthma, mepolizumab, benralizumab, and risdiplam for eosinophilic phenotypes, dupilumab for type 2 inflammatory asthma, tezepelumab for broad non-eosinophilic severe refractory cases. To round out our pulmonology review, let's contrast acute asthma with acute COPD, exacerbations, and COVID-19 pharmacotherapy. In an acute COPD exacerbation, first, oxygen target. We target oxygen saturation is 88% to 92% to prevent hypercapnic respiratory failure. For systemic steroids, we give prednisone 40 mg daily for exactly 5 days. The landmark REDUCE trial showed 5 days is non-inferior to 14 days. Antibiotics, unlike in asthma, antibiotics like augmentin, azithromycin, or doxycycline are indicated if the patient has increased sputum purulence plus increased dyspnea or sputum volume. For COVID-19 pulmonary management, for outpatient early, Paxlovid within 5 days of symptoms onset. For inpatient hospitalized who are requiring supplemental oxygen, dexamethasone 6 mg intravenous or per oral daily for up to 10 days. For rapidly deteriorating patient, add baricitinib, which is a JAK inhibitor, to dexamethasone to target hyperinflammation. Finally, here are the Pharmacist 5 commandments of pulmonology. First, silent chest. It's emergency. A quiet chest accompanied by a normal or elevated CO2 in severe asthma indicates diaphragmatic fatigue and imminent respiratory arrest. Second, oral equals IV steroid efficacy. Oral prednisone is as effective as IV methylprednisolone for acute asthma exacerbations unless GI absorption is compromised. The third thing, stop ipratropium at admission. Ipratropium provides benefit in the ED during the first hour, but offers no proven benefit after admission to hospital words. For steroid duration, 5 days for COPD exacerbations, 5 to 7 days for asthma exacerbations are enough. Finally, smart strategy. Low dose ICS Pharmacotherapy track 1 is preferred as both reliever and maintenance therapy to reduce future exacerbations risk. That wraps up today's clinical breakdown. If these high-yield pearls helped clarify your practice or board clinical pharmacy certificate preparation, make sure to hit that subscribe button and tap the bell icon so you never miss an update. We drop clear, evidence-based pharmacotherapy guides every week to keep your clinical knowledge sharp. Drop a comment below with the topics you want us to cover next week, and follow NextGen Pharmacist across all our channels. Thanks for watching and keep elevating your practice.